Research shows an estimated 210 million women of reproductive age are diagnosed with polycystic ovary syndrome or PCOS in their lifetime, and still many women remain undiagnosed. PCOS is characterized by the accumulation of follicles which are incompletely developed due to an ovulation and can be connected to an increased ovarian androgen production. Due to the hormonal imbalance, several tiny follicles occur below the surface of one or both ovaries, resulting in the development of twice as many follicles, generating slightly larger than normal ovaries. It is important to note that PCOS cannot be diagnosed by a single criterion, as the syndrome is defined as a group of signs and symptoms that occur together and characterize a particular abnormality or condition. Therefore, multiple modalities are required to sufficiently diagnose PCOS, and ultrasound plays a vital role in this. This presentation is designed to aid fellow student sonographers in improving their knowledge and understanding around diagnosing PCOS. To date, there is an adequate comprehensive understanding of the pathophysiology of PCOS. However, patients with PCOS frequently display an increase in the luteinizing hormone and the follicle-stimulating hormone ratio, which contributes to ovarian excess of androgens. Hyperandrogenism is the greatest characteristic feature of PCOS and may be the defining aspect of the disease. Hyperandrogenism is aggravated by hyperinsulinemia and androgen follicle arrest. 50 to 70% of patients who present with PCOS exhibit metabolic abnormalities such as hyperinsulinemia due to obesity and hormonal abnormalities caused by insulin resistance. While the exact cause of PCOS is unknown, results show that individual suspectality depends on the genetic background and lifestyle risk factors. 20 to 40% of females of PCOS have first-degree relatives who have the syndrome, and suggested that the disease is partially inheritable. Obesity increases the risk of constant subfertility and ovulation, and 30 to 75% of PCOS are classified as obese. Research shows PCOS can be developed at various stages of reproductive age and can be portrayed by a variety of signs and symptoms. These include hirsutism, or increased hair growth on the face, chest, or back, obesity, sleep apnea, menstrual abnormalities, infertility, acne, and alopecia, or increased hair loss in a single or multiple areas of the scalp, head, and body.
Until recently, there was no established criteria for the diagnosis of PCOS. However, a global consensus definition of PCOS has now been established and states that a diagnosis can be confirmed when at least 2 of the 3 following criteria are present: oligoovulation or anovulation, clinical and/or biochemical signs of hyperandrogenism, and/or polycystic ovaries, the presence of at least 12 follicles measuring 2 to 9 millimeters in diameter, and/or an ovarian volume in excess of 10 mils, only required in one gonad. It is recommended that the measurement of ovarian volume be utilized only when the assessment of the ovaries is difficult or a transvaginal examination is not possible, as it has a lower sensitivity. The diagnosis can then be confirmed when alternate endocrine diseases are excluded. The type of PCOS is depicted by the combination of criteria the patient exhibits, as shown in this Venn diagram. There are 2 types of pelvic ultrasound probes. These include a transabdominal or TA probe, which is a non-invasive form of imaging. The TA probe is a curvilinear transducer, which has a 3.5 MHz frequency, which allows for higher penetration but lower resolution. The transvaginal or TV probe involves placing the probe inside the vagina. It is a 5 to 7.5 MHz frequency transducer, allowing for lower penetration and therefore higher resolution. Before commencing the examination, a TA scan requires the patient to have a full bladder. Commonly, the patient would empty their bladder an hour to an hour and a half before the scan and then drink a liter of water over the next 30 minutes. It is also advised that the patient's consumption of water is completed an hour before the scan. This allows for the urinary system to accumulate the fluid in the bladder, therefore producing a clearer image while scanning. If a TV scan is required, the sonographer will inform the patient to empty their bladder prior to commencement. For a TA scan, it is recommended that the patient lies decubant in a supine position with the head towards the machine. However, for a TV scan, the patient is required to be in the lithotomy position. This means the patient is to bend their knees, feet flat on the bed, and spread their legs apart while remaining supine. By bending the knees and opening the legs, the technician will have easier access to the vagina and the probe maneuvering will be more comfortable for the patient. Initially, a TA scan is performed to assess any major abnormalities of the pelvic organs and surrounding structures. The TA probe is placed on the lower abdominal surface of the patient, pre-void. Assessment begins with the uterus and cervix along with the pouch of Douglas. Then finally, the ovaries, adnexae, and bladder are examined. It is important to ensure the patient has not distended their bladder so that the ovaries are not compressed and elongated due to excess fluid in the bladder. The ovaries should be measured both pre-void and post-void, as well as in 3 dimensions to ensure an accurate measurement is obtained. If the ovaries are unable to be located between the uterus and iliac vessels, the probe should be moved in a superior direction towards the iliac fossa, near the abdominal wall, or inferior towards the Douglas cul-de-sac. It is important to note that a TA scan should be performed on all girls and women who have an intact hymen and those who do not consent to the TV scan.
A TV scan is an intimate scan that requires written consent by the patient with full understanding of the details of the scan. It is recommended when certain areas of interest show abnormality during the TA scan. The TV approach is the preferred method of examining as it provides a more accurate visual of the internal organs, especially on more obese patients. The probe is covered in a probe sheath with a layer of gel coated on the outside to both lubricate and ensure a clear image once inside the vagina. When completing the scan in a sagittal plane, the probe should be maneuvered side to side. A semi-coronal image can be captured by rotating the TV probe by 90 degrees with angulation in the vertical plane. The probe should be shifted to various depths to gain a wide scope of images and focal zones. During the examination, the color Doppler settings may be useful in evaluating the vascularity of the ovaries. Ultrasound measures the number of follicles and their size, as well as the ovarian size. A normal ovary is visualized as an ovoid hypoechoic structure with few well-circumscribed anechoic cysts or follicles. As previously mentioned, one of the criterions for the diagnosis of PCOS includes the presence of polycystic ovaries, at least 12 follicles measuring 2 to 9 mm in diameter, and/or an ovarian volume in excess of 10 mL. A polycystic ovary appears with a hyperechoic central stroma, as well as an increased volumetric size and a number of anechoic cysts or follicles in the structure. It is commonly described that an ultrasound of a polycystic ovary is a string of pearls located peripherally. As sonographers, we are responsible for recording and analysing our collected ultrasound information, such as measurements and pathological findings in a written worksheet, to help aid a physician in diagnosis. Before the examination begins, it is important to ascertain the patient's clinical history. A detailed description of the patient's symptoms, any previous surgery, family history of PCOS, what contraception they are on, what stage of their menstrual cycle they are up to, as well as the number of gravida and parities. When reporting As sonographers, we are responsible for recording and analysing our collected ultrasound information, such as measurements and pathological findings in a written worksheet, to help aid a physician in diagnosis. Before the examination begins, one of the main differential diagnoses of PCOS is primary hypothyroidism. It is characterized by a decrease in thyroid hormones caused by the failure of thyroid function and demonstrates cystic changes to the ovaries along with an increased ovarian volume. Other potential differential diagnoses include congenital adrenal hyperplasia, whereby excessive androgen hormones are released, Cushing's syndrome, which demonstrates signs of hyperandrogenism, such as hirsutism and acne, and androgen-secreting neoplasms, whereby women experience sudden and progressive hyperandrogenism and early-onset virilization and masculinization.
Currently, there is no cure for PCOS. However, there are ways to alleviate or possibly eliminate its symptoms. It's important to note that the first line of PCOS treatment includes changes to the woman's lifestyle, including exercise, diet, and weight loss, and should be introduced either before or alongside pharmaceutical treatment. The second line of treatment includes pharmaceuticals such as chloroquine citrate or tamoxifen, forms of antioxidant therapy, which specifically target anovulatory PCOS and induce ovulation. Other treatment options include gonadotropin, ovulation induction, laparoscopic ovarian drilling, metformin, aromatase inhibitors, as well as oral contraceptive pills or the levonorgestrel intrauterine system. In summary, this presentation set out to improve the knowledge and understanding of polycystic ovarian syndrome from a sonographer's perspective. As mentioned previously, a diagnosis of PCOS can be confirmed when 2 out of 3 following criterion are present: oligoovulation or anovulation, clinical and/or biochemical signs of hyperandrogenism, and/or polycystic ovary, the latter of which is determined by ultrasound. Our role is vital in providing an accurate calculation of the number of follicles in the ovary, along with accurate measurement to assess ovarian volume. In most cases, a TV scan is preferred method for visualizing the ovaries as it provides better quality image with higher resolution. Therefore, it's important as sonographers that we acquire informed written consent and ensure patient privacy, comfort, and safety, not only for intimate scan, but for all examination. As there is currently no cure, it is vital that we continue to develop our understanding of PCOS and strive for more accurate diagnosis in order to improve the quality of life for the patient.